So my name's James Milligan. I'm a physician by training, a specialist in pharmaceutical medicine and clinical risk management. I'm here representing a charity, first and foremost, looking at improving indoor air quality as a means to improve public health. But I'm also here with one of the exhibitors, Smart Air. My question, which is the simple bit, I think, is for Dr. Wootton. We seem to be very good at sterilising and cleaning everything we come into physical contact with, but should we be shifting the conversation to cleaning the air a little bit more? Thank you.
Thanks, James. Oh, this is working. Yes.
Just so that you know that I'm going to get Dr. Wootton out of jail. He and I know each other. That was part of the disclosure, maybe. But could you elaborate slightly on what we might do? Thank you, sir.
So we haven't prepared this routine, but he did warn me he was going to ask a nasty question. Well, I'm going to cop out a little bit, James, and say that I am not an expert on air filtration or on its benefits in an infection prevention control setting. However, I do know that I've just made the case that nosocomial pneumonia, I think, is at least in part driven by nosocomial viral infection. And I think if you have, or if there are, filtration systems that can sift viral particles or virally infected particles out of the air, that has to be a sensible thing to do. So in Liverpool, we have two big acute hospitals, Aintree, where I work, and the Royal Liverpool. And the Royal Liverpool is where the infectious diseases department is, and they're one of the national centres for managing high-risk pathogens. So if you come back from Central Africa with a fever and there's concern about you having a high-risk pathogen, you go into a negative pressure environment there because of the concern about you spreading your infection outside of that room. If you come into my hospital and you develop nosocomial pneumonia, and if that's potentially driven by a virus, you just sit on an 8-bedded bay, and the best we do is sometimes pull a curtain around you. And I think it is going to be extremely challenging to move from the situation at the Royal Liverpool with negative pressure rooms to the situation at Aintree where there are none, when we're managing 1,100 cases of HAP a year. Even if we were to manage all HAP or all pneumonia in a side room, we don't have enough side rooms, never mind negative pressure rooms. So yes, I think if you can convince me that there is a filtration system that removes the infectious particle, then I think implementing that would be good. I think the big challenge is going to be there is very limited trial evidence for many of the interventions that we do. That sounds like a costly intervention, and convincing funders and policymakers that these things really matter will require high-quality evidence. So I think the dialogue is going to be, how do we design trials that can demonstrate the efficacy of this?
Thanks very much. My name's Martin Kiernan, University of West London. I'm standing over here, sorry, can you see me? It's a comment to Dan, really. So you've talked about HAP, but there's a difference between HAP and VAP, non-ventilator associated pneumonia. And in your risk factors, you presented many surgical cases where people will have been ventilated during the case, unless surgery has changed a lot since I last went in. If you look at the national prevalence studies, the previous two to this one that we're about to get results on, I hope, have shown that pneumonia is the biggest healthcare-associated infection, and it's an 80-20 split in favour of non-ventilator to ventilator. The government know this, because I used to sit on AHA, and we would consider the results every 10 years and go, that's interesting, maybe we should do something about it. And two prevalence studies ago, Public Health England, as they were at the time, wrote a long list of recommendations, none of which were done because there was nobody at the Department of Health to do it, because they palmed it all off to NHS England. In the most recent prevalence study before this one, exactly the same result. The biggest proportion of healthcare-associated pneumonia is non-ventilator-associated pneumonia. Public Health England got wise to it this time and made no recommendations whatsoever, so they couldn't be criticised for nobody doing it. it's about time really somebody started to do it. And I really like your study that has showed this is having such a big financial impact, because that's possibly is what going to trigger action more than just a number. So thank you very much.
Thank you. We've just got time for one more quick question over there. One more question.
While we wait for the question, I might just make one comment. I should have said, and apologies, all the data that I presented and everything I was talking about is specifically about non-ventilator-associated hospital-acquired pneumonia. I'm not an intensivist. I think HAP on the wards is a different disease to VAP. So I agree with what you're saying. The original title asked me to speak to the NHS 10-year plan. I was asked to join the NHS 10-year plan's pneumonia working group on the basis of flying the HAP flag. The group has just been disbanded and I completely failed, and their ongoing plan and the project that they're going to run and fund through the Royal College of Physicians exclusively focuses on CAP and directly excludes HAP from that. So we haven't made an impact yet. Hopefully some of the data that we're going to present will move us forward. So thanks for your comment.
Good morning. My name is Josephine McLean. I'm lead nurse for infection prevention at Alder Hey Children's Hospital. Very interesting presentation. Thank you very much, Dr. Wood. Could I ask whether there are any plans to extend the study to look at paediatrics as well?
Let me think about that. So yes and no. So the current, most of the quality data that I'm showing you is from our surveillance program that we have set up in the Northwest. So I showed you a pilot project, the trusts liked it, the organisers, Advancing Quality Alliance, liked it, so it was set up as a program, and it's ongoing. What's great about that is month by month, every hospital gets data about their rates of HAP, and they can compare that with all the other trusts, and we get together and talk about what's working, etc. All of those hospitals at the moment, all the data is based on adults. However, what we're trying to do with that data, as I've sort of alluded to, is to put it in the face of policymakers and put it in the face of funders and say you need to fund some research in this area and you need to fund ongoing surveillance. And our next wish is to move into the paediatric arena. So we have a number of applications to do, a number of different projects, and one of those includes a paediatrician. To try and think about HAP in the paediatric space. I am not, other than having some kids, I don't know much about kids medicine. So we will need to collaborate with you and paediatricians to understand that better. So we're not doing it yet, but the plan is to move into the paediatric space, yes.